Hi, Prof. Good morning. I'm waiting for. Oh,
Good morning.
Yeah, I think I see him now. อาจารย์น้ำหลาดสวัสดีค่ะ Morning.
Good morning. Good morning, Dr. Sigoroa. Good morning. I
We
saw
must look
just a
forward.
note.
Just making sure that the invite is sent to my fellow who is presenting today. Bear with me just one moment.
Sure, Prof.
And I'm just going to call her now to make sure she has the invite. Wanapa, I just spoke with Dr. Katie Lutz. She's just signing on.
All right. Hello, everyone.
Hi, Katie. Wanapa?
Yes, Prof. I think we are ready. Whenever.
I'm just going to introduce Dr. Katie Lutz to all of you. So, Katie, we're really privileged to, over many years now, have both a friendship and a professional relationship with BDMS and with their centers of excellence that focus on cardiovascular care. And each month we run a CAF conference, and we have the opportunity to present cases that illustrate some of the areas of focus or techniques that Dr. Damras and others have identified with us as things that we want to learn and experience through case based presentations. To our BDMS friends, Dr. Katie Lutz is our interventional fellow, focused on primarily coronary disease, but tomorrow she's going to be making Holy Hearts unholy. And, you know, we're privileged to have her previously as one of our general fellows, and we've been able to retain her and have her develop into an outstanding educator and interventional cardiologist. And so, Dr. Lutz.
Thank you so much, Dr. Sigoroa. I'm happy to be here. I'm just going to share my screen here so that everyone can see my PowerPoint. All right. I'm going to go back to the beginning here. Okay. Perfect. So this is a case that I chose to present. Let me just close this window a little bit. Mainly because, you know, I think we all struggle in evaluating intermediate stenoses, and there's a few different ways that we can do this, and sometimes the clinical scenario calls for utilization of different techniques. And so the title of my case presentation is The Value of IVUS in Intermediate Stenoses, a case of discordant IFR and clinical findings. I want to send a thank you to Dr. Golwala for mentoring me on this presentation here. Okay, so this is our case. This is a 54-year-old male who had initially presented to us who had initially presented to his outpatient general cardiologist with CCS3 angina, so angina on moderate exertion, who was eventually started on isosorbide mononitrate and metoprolol without much relief of his angina. His major comorbidities included HIV, hyperlipidemia, and ongoing tobacco use. And so for the initial diagnostic workup, a stress echocardiogram was ordered. And it showed this. So about 10 minutes into exercise, he started to get a little bit lightheaded. He had a little bit of chest discomfort, and he ended up having multiple episodes of ventricular tachycardia. Although none of them reached about 30 seconds, this is kind of the morphology that it was. On echocardiogram, his wall motion was reported normal, but it was stopped but the test was stopped early because of the dizziness and chest discomfort and lightheadedness. And because of the ventricular tachycardia, he was sent in to the emergency department for further evaluation and workup. So this is his initial coronary angiogram. His right coronary artery was essentially normal and isn't included in this. But we can see here on this AP caudal view, his left main looks essentially normal, a little bit of luminal irregularities in the left circumflex here. He has a large ramus intermedius artery here with maybe mild stenosis at the ostium. And then here in his LAD, he has somewhere between a 40 to 50% angiographic stenosis here in the AP caudal view. When we moved up to, this is either an RAO crani or an AP crani view, the stenosis looks slightly more severe, potentially in the 50 to 60% range, but otherwise there wasn't anything significant, at least hemodynamically appearing significant on coronary angiogram. Just another couple of views. We tried to take as many orthogonal views as we could and used high definition on this last shot as well in the LAO crani. And again, it appeared to be at least in moderate severity. And so because it was in the moderate severity range, we decided to use iFR to further evaluate for hemodynamic significance given the positive stress test findings. And in the beyond the lesion in the mid to distal LAD, the iFR was 0.92, which the cutoff is 0.89 from all the trials. And when we pulled back, there was a discrete focal pattern where it went from 0.91 kind of back to 1.0, and significantly no evidence of drift on pullback. But again, still not meeting our cutoff of 0.89 for hemodynamic significance. And so at this point, given that he is 54, he's having significant symptoms, and just from iFR at least, non-hemodynamically significant stenosis, and yet symptoms plus a positive stress echo with ventricular tachycardia, we had to decide what we were going to do as next steps for him on the table here. And so a couple of different options, which I was thinking that we could either discuss or I'm happy to discuss our thought process for each of these, is, we thought about, can we just medically manage him? He's on 2 anti-anginals already and still having symptoms. Should we just stent this? Should we pursue further hemodynamic testing with FFR to really prove that this is hemodynamically significant? Or could we potentially use IVUS as another tool? And I'm happy to pause
So-
here. Mhm.
So, Katie, what did you think about the rhythm abnormality and what that signified and why? And then I'm going to ask Dr. Damras for his thoughts, as we have had lots of wonderful conversations about how we assess intermediate lesions. But what were your thoughts about that stress test?
Yeah, so the rhythm was a monomorphic ventricular tachycardia, which the typical mechanism for that would be more of like a scar mediated based tachycardia rather than if it were polymorphic. I would consider it, I would bring me a higher level of suspicion that there was acute ischemia ongoing. But I think, you know, the ventricular tachycardia plus chest pain during exercise did raise suspicion that there's something going on, but I think it's not really a slam dunk.
Yeah, thank you for your high presentation, but you are a little bit more advanced than we are. But under BDMS, I always urge all the interventionists first to do QCA online. That is something like a gold standard to do QCA online and measure for the MLD. If MLD is below 1.0 millimeter, it could be correlated with the abnormal FFR. But you start with iFR, and iFR is borderline 0.91. We consider 0.89 as a significant. And from 0.90 to 0.92 is borderline. I will definitely go further for FFR. And under BDMS, we urge all the interventionists to use intravenous FFR instead of intracoronary. I myself, I believe in intravenous FFR, and we are on the process to ask the BDMS group to import the adenosine triphosphate. Adenosine triphosphate. It is not diphosphate. It is triphosphate that packaged in a powder of 100 mg, 100 milligram. Then you can dissolve into the 5% dextrose in water, and you can infuse intravenous into a central vein, maybe a brachial vein or femoral vein, at 140 or to up to 160 microgram per kilogram per minute. That is my usual when you start with iFR of 0.91, that is borderline. And second, under BDMS, you mentioned about 40 up to 50%, but we prefer our interventionists to use Jensen score to make sure that everyone speak in the same international language. So in your case, the lesion is around 26 to 50% diabetic stenosis. That is borderline. It's not so severe, but there is something. I agree that in the cranial view, there is something on the proximal LAD, but I'm not sure with the MLD and borderline iFR. So I will continue with FFR before we go to IVUS.
So those are really wonderful points. And when I think about this, and we'll see how Dr. Lutz and Dr. Galwala approach this, I think that medical management without an additional step invasively doesn't meet the sniff test given the symptoms and a life-threatening rhythm. I would have been happier for the rhythm to be polymorphic, as you mentioned, Katie, but I think that, you know, the community standard independent is further detailed investigation. The second point I would make is no test is perfect. And when we think about the scatter plots and how we figure out what the area under the curve is and the sensitivity specificity, There is variation, and ultimately somebody has agreed plus or minus 2 standard deviations and set what that discriminatory value is. And it's going to be tested against some gold standard. So you had FFR, and then in non-inferiority trial, you had IFR, and then in non-inferiority trials, you had the black box computer AI entities. So I myself would not simply do medical therapy, and I would likely pull in a complementary study that has different foundational principles relative to thresholds for ischemia.
Yeah, those are all really excellent points. I think a lot of interventionalists may reach for FFR as the next step, because this is, again, as you were saying, it's a borderline IFR with resting index. And so reaching to FFR and getting the patient to hyperemia with adenosine, I think is extremely valid and would be an excellent next step. For this case, we did end up deciding to use IVUS as the next step. And I'm just going to go over one of the trials that we found useful recently as we were considering what to do next. So this is the flavor trial. So it wanted to compare, it's the largest randomized control trial that compared FFR guided PCI to IVUS guided PCI, and was a non-inferiority study. They enrolled, their target was around 1,700 patients who were 19 and older, who had suspected ischemic heart disease. And they all had to have a coronary angiogram with de novo intermediate stenosis, as in they defined this as a 40 to 70% on angiogram in any target vessel that was greater than 2.5 millimeters. And so the patients for the FFR guided arm, they were randomized 1-to-1. The FFR guided arm, if they were less than 0.8, they would put a stent in. And if they were greater than 0.8, then they would medically treat these patients. For IVUS, they would either stent the patients if they had a minimal lumen area of less than 3 millimeters squared on IVUS, or if it was in the 3 to 4 millimeter squared range and the plaque burden at the lesion was greater than 70%, then they would place a stent there. Otherwise, they would get medical treatment. And so they followed these patients for initially for 24 months, and then extended this out to 7 years, which I'll show you both the primary points from the data from that trial. Okay, great. So at 24 months, the FFR did meet non-inferiority, and the syntax score for all of these patients, again, non-left main lesions, and for pretty much all of them, the syntax score in both the FFR and the IVUS groups was around less than 10, with an average of about 8 to 9 for both the FFR and IVUS groups. So not necessarily complex lesions, but the FFR and IVUS group, at 24 months, they had essentially the same cumulative index of major adverse outcomes for both groups. And so when they extended this follow-up to close to 7 years, they looked at not only the per patient outcomes, but the per vessel outcomes. And I'll just walk through these graphs here. So the main takeaway from the per patient outcomes is that there was really no difference in the patient-oriented outcomes, which is their symptoms, their all-cause death, myocardial infarction, But there was significance in revascularization, as in the FFR group out at 7 years had an increased rate of revascularization compared to the IVUS group. And when we look at the patients who were medically treated, the patients who were medically treated for both of those arms in both the FFR and IVUS, the main significance here is that patients who initially were randomized and did not have a significant lesion in the FFR group did end up undergoing revascularization more often than those who were in the IVUS group and didn't meet the cutoff for revascularization. So if we look down here at the target vessel PCI at index procedure and at follow-up, again, we see these similar trends of target vessel revascularization. So look across at the bottom here. This is 1, 2, 3. Each of these is the year since randomization. The blue shows the FFR and the green shows the IVUS group. And you can see that more often, the people who were in the IVUS group got stented up front, but the percentage of those who ended up getting stented when they came back for repeat revascularization was somewhere around like the 1.5% from 1 year to 7 years, whereas it's around the 4% of patients who had initially undergone randomization to the FFR group. They ended up getting revascularized more often by 7 years. Now, when we look at hard outcomes such as death or myocardial infarction, there was really no difference in the incidence, and that's this line at the top here, between both IVUS and the FFR groups. So a potential takeaway that one may find is that, you know, we can theoretically, probably safely, not use IVUS potentially when we're thinking about revascularizing intermediate appearing stenoses when we compare that to FFR. But you're likely, if you're using IVUS, going to end up stenting more often if you utilize a potential cutoff such as this, without really a change in the incidence for death or MI. So for our case, our patient ended up having, this is the IVUS pullback here. So if I can pause it, and I'll just drag this here myself. So this is the kind of mid LAD here. And as it gets pulled back, you can see that there's a very large plaque burden here, nearly 270 degrees. And certainly as we pull back into the lesion, right around in here, we're seeing that there's certainly greater than 70% plaque burden with a very large amount of non-calcified plaque here. And then when the LAD joins in with the circ here and comes to the left main, there's certainly less. When we measured it, took some measurements on IVUS, they're again greater than 70% plaque burden with an MLA of around 3.8. So this patient would technically fit in the group that you could consider revascularizing based on this trial. And so that's what we ended up deciding.
You know, if we pause right there, Katie, when we think about historical trials and you look at minimal luminal diameter, really most of the trials showed anywhere from a 1.7 to about a 2.1. And it's really hard to pass an IVUS catheter through and get anything smaller than 1.7. And so this is a lesion that, number one, involves all 4 quadrants. Number 2, has very little calcification. And 3 has an area between about 130 and 3 of echolucency. within it. So there is a component of this lesion that is complex and plaque rich. And in fact, you would say likely has a thin cap atheroma to it between 1-ish and 3-ish as it. So this is in some ways, compared to the angiogram, much more concerning.
Yeah. Yeah, I would agree. And I think that that's what we thought when we looked at it as well. Particularly looking at how large, when I go back to the IVUS, how large, the distal reference area was here. I don't have it mapped out, but it's certainly a lot bigger than in
4
here where,
millimeters.
yeah, exactly. So it's certainly a lot larger than the MLA here. So yeah, so we were very concerned about this, and so we did, and given the lesion characteristics, the large area of non-calcified plaque, and like Dr. Sigaro was saying, likely thin cap fibroatheroma, symptoms, the VT on stress test, we did decide to stent the patient, and we did use IVUS to guide it, although I don't have those images with us. We did have excellent stent expansion. I believe that we ended up it was a 3.5 by 18 stent, and we ended up post-dilating it to 4.0. And he had an excellent result. At around the 2-week follow-up, he reported essentially resolution of his symptoms with exertion.
So before we go there, Katie, will you play this image one more time?
Mm-hmm.
So I'll be interested in hearing from the audience, including Dr. Damras, what his thoughts were on the discordance between the imaging by IVUS and angio as the first question. And the second is a really interesting finding as to whether anybody in the audience has ever seen a ventricular arrhythmia caused by a myocardial bridge, because this person has a substantial mid-LAD myocardial bridge.
Yes, I also see that myocardial bridge at the mid-LAD. But on this case, it is very unusual that you have a thin cap fibroatheroma on the negative remodeling segment. What you show is the smaller segment in the disease itself. And when you mention about thin cap fibroatheroma, we usually see the positive remodeling, not negative remodeling. Always negative remodeling always came with the fibrotic lesion and all chronic lesion, not in thin cap fibroatheroma. That is one thing that is very unusual. And second, when you implant a stent, you have to implant the stent according to your distal landing zone and try to open up or do a port at the negative remodeling site. And of course, you have to be careful of the coronary rupture. That is the point. And for the myocardial bridging, I'm not sure that you drag the EP guys in your team come in and do some tests to see when you fix this coronary lesion, is it VT disappear? Because he's young man, and I guess he's a jogger. The running, jogging every morning. And I wish that his family will be very, very highly conscious about the VT during the exercise.
Mm-hmm.
Yeah, I'm really going to be fascinated by whether he has VT moving forward or not, and whether Dr. Lutz and colleagues felt that beta blocker therapy would be indicated, and whether or not this person should undergo a repeat stress test and or a Zio patch.
Mhm. Yeah, that's an excellent point. I think we'll kind of have to see how he does longitudinally, since he did have pretty rapid resolution of his symptoms. He is on beta blocker therapy, metoprolol succinate 100 milligrams, and we'll definitely have to be following him up. And if he still has at least some symptoms, I think and even in the absence of symptoms, I do think a Zio patch is an excellent idea. I had not considered doing that before, but we certainly can do that. And I'm not sure that we've routinely gotten EP involved, but that's a really interesting question on if there's a myocardial bridge on getting them to weigh in on it.
Yeah, I would, at a minimum, on beta blocker therapy, stress him. And it doesn't need to be a stress echo. It can be a standard Bruce, and make sure that he doesn't have it. And then in his ambient life, would think prolonged monitoring would be important. And in the old days, when we took ACS patients and treated them with fibrinolytic therapy, not everybody came to the cath lab, in the early 90s. And everybody got a exercise nuclear test, and everybody got a discharge Holter monitor. And then after they convalesced, often got a repeat stress test for those people who had had infarction. So I would extrapolate here and say he had a nasty ventricular arrhythmia with exercise, and he has residual atherosclerosis, and we've not excluded the impact of the bridge, nor the impact of abnormalities of his microcirculation, and I bet both are present.
Excellent. Any other comments before I move forward for some of our take-home points?
Yeah. In the past, I always confident that myocardial bridging is just a incidental finding, and there is no impact at all. 100% believe. But finally, in last few years, I found some articles about the myocardial bridging with sudden death. So I changed my mindset. I said, oh, myocardial bridging is not just the bedside story for the children, but it's a real threat. It's a real threat. We don't know that who will die. So I changed my perspective when I found this myocardial bridging. There is something that we don't know yet, but there is some articles. At least I found 2 articles that mention that myocardial bridging and patient have a sudden cardiac death. So it is not just a toy game. It's something that you should worry and concern.
I'll make one more comment, Katie. That's the beauty of these meetings, because it just stimulates so many interesting points. The walls of the coronary artery in a myocardial bridge tend to be elliptical, and their media is different. They're thinner walls, and they have increased risks of perforation when you do PCI on them. In addition, increased rates of fracture. and increased ISR. And so really think twice about doing PCI to a bridge segment. And if you're going to, make sure you image it and undersize and be careful with your adjunctive pressures because these are horrific perforations when they occur.
Yes, I was actually preparing an IVUS lecture for later on this week, and I wish that I would have included the images in this presentation, but we had a beautiful IVUS image of a myocardial bridge where you could see it collapsing right around. And I agree, Dr. Figueroa. I don't think that I realized how much thinner the walls are in that segment until I was able to review that IVUS image as well. All right, excellent. I'll move forward with the take-home points for this talk. Is that, you know, there can certainly be discordance between anatomical and physiological assessments which we do in the cath lab, and I think at least for this case, integration of all of the data points, including the clinical history, is critical. If we would have had a patient who maybe had some wishy-washy symptoms and you know, it just didn't really fit the same profile as this patient, I think nearly everyone may have said medical management, but because we knew all the backstory and the positive stress findings and all of this, you know, it was really critical for us in not only doing IFR, but then in taking it even further to a next step. I think in the future, our field is probably going to move toward further studies of anatomical assessment in conjunction with hemodynamic assessment. And I don't think it's going to be a one size fits all. And I think that really they're going to be very adjunctive and will help us to guide individualized treatment decisions for patients.
Yeah, I certainly sense that in conversations at national meetings in the US that there is the pendulum swinging more towards intracoronary imaging and not always answering FFR or IFR. I was not at the European meeting just a couple of weeks. Dr. Damras, were you there this year?
No, I just attend EuroPCR on May.
Okay. But there is more of a movement, I don't want to say away from physiologic testing, but I would say towards intracoronary imaging as a one-stop shop. It obviously doesn't separate when symptoms are due to epicardial versus microvascular. But I think people are feeling pretty comfortable with the cutoffs that you've mentioned to guide proceeding or deferring. And as you pointed out, proceeding with IVUS to discriminate places you in that basically 60 to 65% category of proceeding with PCI. And what they haven't given us yet in that group was quality of life relative to angina burden. They gave us, quote unquote, the soft hard endpoints, but that's a big part of it. And so when I look at the totality of the data, there's no harm by using IVUS. there probably is an improvement in quality of life, and there's a less need for repeat procedures moving forth. And if you use the IVUS to guide your PCI and do appropriate plaque modification and great stent deployment, then we now know that that reduces myocardial infarctions over time, as a Renovate complex trial has demonstrated. So I think this is a fantastic case. It illustrates there is no perfection, but sniff test is critically important. And the sniff test here suggested that ischemia was likely playing a role in symptoms and in monomorphic VT.
If you look back to the historical data of FFR, I used to visit St. Catharina in Eindhoven in Holland. There is a house of FFR. I mean, they produce a FFR bag solution. I mean, in-house. I mean, they did 25 cases a day with adenosine FFR. But the point is that for us, it is a financial constraint. We cannot use both of them. I mean, we cannot use FFR, IFR, and IVUS. So we set a strategy like this. First, patient have to do non-invasive test. If non-invasive test is positive or is suspicious of something, you take IVUS. IVUS is something like a sword. When you open the sword, you have to strike. But if there is no non-invasive test, patient could not tolerate any kind of stress echo, the vitamin echo, or whatever, and you have a borderline lesion, then it is time for you to pick up IFR and adenosine FFR, and it is a healing sword. Healing sword means you do not need to strike. You have to defer the PCI in a lot of a number of cases. That is my usual, when I visit or under BDMS, I always told people like that.
Well, Katie and I were having the discussion at CAF conference. I missed the majority of it last Thursday, but the discussion was FFR, and I walked in 52 minutes late. It didn't keep me from providing perspective. I know all of you are going to be surprised by that, but I said we can't afford to do all of them. And, if I have to choose, I will choose intracoronary imaging as my primary modality to discriminate, because it can do one thing pretty well, and that's discriminate when to intervene and when not. And it can really do the other well of plaque modification and adequate stent expansion. So I'll always pick imaging. Well, I'll usually pick imaging over physiologic testing alone. And picking both physiologic testing and imaging is economically not viable.
I do think we got a question in there, was what was the MSA after we deployed the stent, and what was the IFR? I wish that we would have, that I can say that we typically put the IFR back down and make sure that we've made a hemodynamic improvement, but we truthfully typically don't do that here. We do post PCI IVUS, and I should have included it in here, but the post PCI MLA was somewhere between 10.4 to 10.8 millimeters squared, which was very similar to what the distal reference vessel was.
I have one question for Professor Sigurua. How about the progression of the FFR-CT right now for the diagnosis of the significant cholestatic disease, FFR-CT?
Yeah, so it's again a validation set off a validation set off a validation set. What I will tell you is that our NCDR registry includes that as an appropriate use criteria to intervene when it's significant. And so I think that where I'm challenged with that number is when it's done as a screening coronary CT in an asymptomatic patient, do you use the same prognostic significance of a worse outcome as we did when we validated FFR in patients with an abnormal stress test and symptoms, and then either deferred or proceeded? That's where I wind up with the challenge. And then medical legally, people in the US will argue, well, physiologic testing in the cath lab prognostically, when significant, demonstrates an increased risk. And so why doesn't the CTA do that? And so in the US, we're very litigious as it relates to medical legal, and I worry about that. But I think the shortest part of it is it's an accepted part of AUC now in cath PCI.
Thank you.
And I guess FFR CT is available only by HeartFlow company. You have to send CT scan to HeartFlow until the patent is over, 10 years patent. And then every company can perform the FFR CT. HeartFlow is in California, as I guess, and they charge quite a lot. We send one case, they charge $3,000 for just a measurement. And for Dr. Katie, thank you very much for your beautiful presentation. But for completion of your presentation, I want to see IVUS for the minimal stent area, post-stenting, and also the stent position, stent expansion, edge dissection. If you can show your IVUS to us for completion.
Yeah, absolutely. Let me take it off of here, and I will have to. I'm wondering if maybe I can bring it for next time, because I'll have to look at some
de-identify it.
PHI. Yeah.
We'll show it next time, Damras.
Thank you. Anyone else have question for the presenter?
Yes, for the myocardial bridging, I would like to ask in your experience about the role of myotomy in this such case. In this case, with the refractory angina with full medication, what is the role of myotomy? Thank you.
Sure. So there's a great review paper that I'll share with the group in JACC several years ago. And I found it a really well-written construct. The first was the importance, when that's the only abnormality, to perform FFR, to understand the physiologic significance. You know, there's no atheroma. The second is medical therapy can be effective, but it's just so-so, but it is the first line. No true benefit of calcium channel blocker over beta blocker or beta blocker over calcium channel blocker, but diltiazem, verapamil, metoprolol, atenolol, all reasonable. No good data with carvedilol, and wondering whether the alpha component of it is beneficial or not. And reserving the unroofing of the bridge when patients have symptoms despite whichever agent you start. Ranolazine, no great data on ranolazine in myocardial bridges. So I myself only have a few patients that have undergone unroofing, and it's an uncommon procedure. So having one of your surgeons be the person, the technique is different than bypass, I think is really important. And the two that I sent to our surgeon who has the most experience, which is not a lot, they've done beautifully with relief of symptoms and beautiful post unroofing stress tests, which has shown normalization, and then beautiful CT scan that showed that it was no longer embedded under 5 to 7 millimeters of myocardial tissue.
Thank you very much.
Anyone else have a question? We still have some time left. ใครอื่นมีคำถามไหมคะ
I am Dr. Watanyu from Bangkok Hospital, Phuket.
Good morning.
Good morning. Sorry. How much about the iFR after the procedure?
Yeah, I wish I could say that we typically do iFR afterwards, but we usually don't use iFR after we're finished with procedure and go mostly by anatomic assessment with IVUS. And again, I apologize. I should have included the IVUS images, and I'll definitely include that on the next slideshow. But we had a substantial improvement on the post IVUS images. I just don't have the iFR data.
So there's no doubt that the use in the absence of IVUS of lesion-specific drops and to understand where the gradient begins to appear and co-register that with your angiogram is very helpful to determine the stent length that you are going to plan. And then two, again, in the absence of the use of image-guided dilation / lesion prep, that normalization of the iFR or FFR values is predictive of symptom relief and short to intermediate outcomes. I myself don't believe that it is of additional value to image-guided stent optimization and determining quote unquote normal to normal. And so once I cross over into image-guided intravascular stenting, I don't repeat it.
Dr. Katie, can you go back to your slide to the IVUS of the plaque burden 70%? I want to, yes, okay, this one. Actually, we have to measure two things. First, the EAM area, and then use the EM area and minus the minimal lumen area, and that is a plaque area. And then from plaque area, you have to calculate for plaque burden, because a lot of our interventionists, they are still confused about the plaque area, plaque burden. The most important parameter that you have to put into your slide is the EAM area. That usually is big, something like 9 in this case. And then you minus the minimal lumen area, and the rest is plaque area. And then 1 minus plaque area divided by EM area is plaque burden in percentage. Beautiful case, beautiful case. but still miss some of the measurement.
Yeah, absolutely. And yeah, thank you so much for that comment. I actually tried to pull this back up on our nice IVUS screen, and it deletes the cases after 2 weeks on there, so that I couldn't make another really nice circle on here. And so when I tried to make that, it just within our actual software, it just was not very, it was not very good. But yes, absolutely, I should have included, I believe this was somewhere around like what you were saying, around 9.8 at this portion here, which is what I calculated the plaque burden to be.
We get what we call image degradation due to compression of the zeros and ones as they transfer to the PAC system.
Anyone else before we finish? Okay. Thank you very, very much for the very detailed sharing with us today. We learned a lot. And thank you, Prof, too, for having her with us today.